Welcome. My name is Scott Connard. I'm a family doctor and the co-founder and partner at Converging Health. I'm also, and more importantly, I'm the treasurer of PC4AA and on the board. Thanks for joining us so much this evening. We're now almost 850 people from 40 states, but more importantly, we've had over 1,200 people join us on a webinar or a production like tonight, and we're so excited. We have people in 40 states and the District of Columbia, as well as 350 odd zip codes who are building this movement together. The crisis in healthcare and primary care is real. The healthcare we have is too damn expensive and it doesn't do a good job protecting and improving people's health. Not enough people have good primary care and a clinical primary care and a good clinical primary care team. I've listened to the high-level bureaucrats, the politicians, and the money guys in healthcare, and I know as well as anyone that there's no one in charge. The cavalry isn't coming, and there's no one to fix us. Can I get an amen?
Amen.
All right. Well, I'm thrilled that we're going to hear from Gary Knaus, family physician at the Valley Health Alliance in Colorado, and how they've increased their number of people in their community getting regular primary care to over 60% and climbing. That's amazing. I work with corporations, and we're lucky to have 40% of people have a primary care clinician. So to do it in the community and get to 60%, rock on with your bad self. That's what we need all over the United States of America. Please stay on at the end while our board joins Gary for Q&A. We'll be talking about how you can bring primary care to every person in your own neighborhood and community. Speaking of community, I'd like everyone to welcome Callie Ortega to tell us about her experience with primary care. Hi, Callie. Would you tell us a little bit about you, where you're from, and your experience?
Absolutely. And thank you for having me. I'm Callie Ortega in the Chicagoland area and am very passionate about primary care and access to primary care. This past February, my father had been diagnosed with stage 4 cancer, and it was the most devastating season for my family and I. And we were blessed to have Dr. Monica Fudala as our family direct primary care physician. She truly was an absolute blessing. She's been the most compassionate and supportive and insightful primary care doctor that I've ever worked with, that I've ever known. And from the moment of his diagnosis, she literally stepped in and she began coordinating care, speaking directly with the specialists, and there were a lot of them. She spoke directly with the specialists. She made house calls when it was difficult for us to get around. She came and she checked in at home. She visited my father during his last days in the hospital. And all along the way, she ensured that my mom, my dad, and I all felt supported and informed and brought us some sense of stability and comfort, especially when things felt really uncertain in the current medical system, in the hospital setting. She was there for us. And her care, it extends beyond that experience with my father. My mom is now facing advancing Parkinson's. And the way that Dr. Fudala, just her practice and her bedside manner, she works with my mother in such a way that truly empowers her. And it's helping her to maintain her independence and dignity. And it's just an incredible relationship. And having her as my personal doctor as well, she calls me regularly to check in to see how I'm doing and reminding me that caring for myself is incredibly important through all of this as well. Um, really having spent many years in the health insurance industry, I know the system very well. And what Dr. Fudala does goes far beyond what any system that I've seen offers. What any other system does, it's priceless. And in reflecting on the experience that we've had with her and that help, I can't help but think about all of the other Americans, the millions of Americans that would go through something similar and who's in their corner in those moments of need, and helping them to understand a really difficult and challenging medical system, and just having that sense of comfort. Nobody should have to face this alone and without a guide who truly cares and who truly understands the system. And so, while I'm filled with gratitude for having Dr. Fudala in our lives, knowing that so many don't have this type of a champion makes me both angry and determined to be part of a change. And I genuinely hope for the day when everyone has access to that human connection, that expertise, and the compassionate care that Dr. Fudala embodies. She's a true example of what family medicine should be.
Wow, thank you so much for helping us appreciate the journey you've been on. So sorry for the challenges you've had to go through, and also so glad that you have a doctor like Dr. Fudala to be with you and now to take care of you
Yeah.
and maybe the family that you'll have one day. So what a gift.
Thank you.
It's now a great pleasure to introduce our moderator for this evening, Gabriella Yaru, and to thank the Zoom committee of PC4AA, which has organized this Zoom, all the presenters, and John Wright, Brian Kieser, and Patty Armstrong, and again, the ACE Zoom producers. We're so lucky to have them. Take it away, Gabrielle.
Thank you so much. Hi, everyone. I'm Gabrielle Yaru, and I wanted to thank you all for coming tonight. Being here makes you a part of this movement as we together learn the tools we need to provide healthcare for people, not for profit, in every neighborhood and community. Please take a second and write where you are from in the chat. That way we can see who all is here, and as we work together to build this movement. And as we work together to create a welcoming environment where everyone can contribute their unique talents and ideas equally, please, no professional titles. Let's talk about the importance of being here together, engaged in this work, and the value of those ideas and commitments, which are what will build this movement at the end of the day. It's my pleasure to introduce tonight's speaker, Gary Knaus, MD. He's a family physician with a rural practice of 43 years in Western Colorado. He is the 2017 Colorado Family Physician of the Year, Medical Director of Community Health Plan, and author of Achieving Practical Professionalism 2024. For tonight, we are here to both teach and learn from each other. We encourage you to ask questions, put them into the chat, and at the end, when we have time, we'll answer as many as possible after we hear from our keynote speaker. We'll try to end the formal program right at 9 p.m. Eastern, 6 p.m. Pacific time. But we invite everyone to stay on for an interactive half hour at the end where we talk and discuss, plot, and plan. Now, I'm very pleased to introduce our keynote speaker, Gary Knaus.
Thanks so much, Gabrielle. It is my pleasure to offer some thoughts for furthering community-based primary care. The Valley Health Alliance is a collaboration of providers, hospitals, employers, insurers, and the community, where they can actually literally sit at the same table and solve problems around our local health care. This organization has served as a framework for how we deliver care in our communities. I'm coming to you from Western Colorado, my small town, Carbondale, in the Roaring Fork Valley of Western Colorado. From the mountains of Aspen, 60 miles west to the ranch lands, there are, in our communities, there are 9 rural towns and communities, 3 hospitals, 2 of which are critical access hospitals. There are 6 major self-insured employers comprising 7,500 employees. We have 16 advanced primary care practices, including peds and OBGYN. We have a very committed local insurance partner, Rocky Mountain Health Plans, and we have an award-winning health information network. All of this together, we have built a collaboration for the community benefit to stabilize costs, keep care local, maintain viable health care and other businesses, and support thriving providers. We like to use the byline, right care, right time, right place, right price. Our structure includes a governing board, a clinical advisory board, a data committee, an HR working group, and a financial advisory committee. We have staff directors and are aligned with and supported by our clinically integrated network in the greater Western Slope. That's our basic structure. To try to explain our work, I've dialed down to 10 essential elements that we feel are most important for what we do. I'm just going to list those. We've made the following elements of advanced primary care the centerpiece of our approach to care. This includes access, continuity, acute care capabilities, chronic care management, prevention, care management and coordination, behavioral health integration in our practices, screening for social determinants, and measuring what matters. These elements are incorporated into our practice scorecard and are explicitly measured and tracked. In addition to our fee-for-service approach, our 6 major employers commit 1% of their total healthcare spend to a risk-based PMPM payment structure tied to this scorecard and to attribution. This is designed to support the non-reimbursable components of primary care, behavioral health, etc. Hospitals are at the table, both as providers and as employers. I say this gives them more skin in the game. With benefit design, the employers incentivize and we measure attribution to a PC or to a primary care usual source of care. We measure and track primary care spend in the system. We have a data set to inform active management by both employers and providers, focusing on risk level care management, disease-based population information, rising risk patients, attribution, avoidable ER visits. We're integrated with their EAPs, and we measure preventive care rates. We work to integrate the employer's HR programs, wellness functions with the practices, including preventive care visits and labs, chronic disease education, primary care principles, their EAP, and add clinical input to their benefit design. Employers, we have arranged that they can now access a new VHA-sponsored pharmacy benefit program, already saving hundreds of thousands of dollars. And we have arranged a common stop-loss carrier for these businesses. One of the important parts of this is a committed insurance partner, Rocky Mountain Health Plans. They have an individual plan that they market. They are the Medicaid provider for the Western Slope, and all of our primary care practices participate in the Medicare ACO. This is another 12,000 lives that we actively manage and track with an integrated data platform, including the VHA lives. And we have integrated the quality measures, so we have all the same quality measures for each line of business, and we are the ones that chose them. Uh, we have 2,500 small businesses in this valley, and they don't have a great source of insurance and coverage for their employees. We're rolling out a new ICRA plan to help them. One of our exciting developments that we're just starting on, we received a $100,000 HRSA grant specifically designed to partner with our 3 county public health agencies to develop a specific messaging strategy for the whole community about the importance of having a primary care home. We're just beginning that work and think that that can be spread to other places. I want to mention some results that we have seen from this collaboration. We've had very stable insurance rates over the past 3 years. Our benchmark spend is going down for all these lines of business. Insurance company tells us that our tier 1 advanced primary care practices spend about 10% less Medicaid dollars than the non-advanced primary care practices. We track and maintain very low avoidable ER visits, have low hospital inpatient rates. We track primary care spend, and we're in the 5 to 9%, depending on which employer we look at. Talking a little bit about attribution, we have now reached 68% attribution for our 6 employers. This is incentivized and tracked. By definition, in Colorado, if you are on Medicaid, you have a primary care doctor. Same thing, more or less, for the Medicare ACO. And so those attribution rates are in the 80 to 90% range. The Commonwealth Fund reports that Colorado, on average, is about 80% attributed to a usual source of care. Lastly, I wanted to share some lessons learned. We kind of keep track of this, and I always say it's complicated and incremental, so we have to be patient. We have learned that we have to continually educate employers, patients, and hospitals about the complexity and nature and benefits of primary care. We're at least at the point where folks like the idea of primary care, but people still really don't appreciate the wide breadth that primary care and the value that it brings. Hospitals, insurers, and patients need to be our partners to move primary care forward. I think we are kidding ourselves if we think that we can build it and they will come. We need to have partners in this enterprise. We have learned that team care has to be real team care, and it has to be incentivized and valued. I think we've learned that behavioral health integration in our practices is probably the key element to quality, to cost, and to provider thriving. Totally changes the nature of what we do. We talk all the time about measuring what matters, and we are beginning to implement system-wide the person-centered primary care measure that came out of the Larry Green Center. And if people aren't aware of that, I think that might be the takeaway message for the night, to read that, review that, and Rebecca Etz has done a fantastic job in designing that. We also have learned that employers feel helpless to control costs, and we can help. And that's what we're all about. We feel like we're making progress, but there's plenty of work to do. Those are the comments that I have. Thanks.
Okay. Thank you so much, Gary. If anyone has any questions, if anyone has any questions for Gary, please post it in the chat. We want to be able to go through and ask him what you guys have on your mind. Together, we can make sure that everyone in the United States receives equitable health care and gets equitable health, regardless of where you live, how much you earn, what community you come from, or what you look like.
Thank you so much, Gabby. And thank you, Gary. As questions come in, I have a few that we can get started with, if that works for you. Sound good?
Good, good.
All right. So it sounds like you've gotten everyone who's anybody in healthcare around Aspen involved in the process, right? It's super comprehensive. Have you been able to include community organizations like the Rotary or school boards in your process? And if so, how have you done that?
You know, a couple of things. You mentioned schools. During COVID, we developed some really robust partnerships with the school system, and we are partners. One of our participants is our local FQHC provider who has 4 different sites in our valley. They have integrated healthcare in the 3 of the high schools in our communities, and that's part of the primary care picture. We have a representative from the 5 chambers of commerce on our board of directors, and they are our liaison to the small businesses in the community that we're trying to work with. So that's one of the things that we're doing there.
Yeah, I mean, it's smart to try to engage. Did you seek them out or did they seek you out in that process?
We've sought them out. We've tried to be
Okay.
inclusive in this collaboration with them.
Okay.
Yeah. Yeah.
Okay. Now, is there anyone who's like sort of on the fringe or left out of the process that you would like provide access to these folks?
You know what, one of the things we learned, I think, from looking at our data, you know, that 38% that's not attributed, 32% that's not attributed, by and large, we think that 20% of it may be folks who just don't access the healthcare system. They like alternative care. We are in a community with a lot of I don't want to, well, a lot of entitled people who move toward the concierge practices that are not part of our system. I guess the autocrats need healthcare too. We do find that a lot of the folks who aren't attributed are those young, healthy, probably males more than females, and just not needing health care. That's last on their list of things to think about, and it's a struggle to get them attributed to a primary care practice.
Okay, so I mean, it sounds like
But
you've done a really impressive job with getting more people into primary care. Any thoughts about how to bring those people that maybe have access on paper but don't really have a primary care relationship yet?
That's what we spend a lot of our time thinking about, and we haven't solved that yet.
All right, so if anyone here has the answer to that, they can also put that in the chat.
Yeah. I would also mention that there are now 15,000 patients that access the FQHC, and half of them have lost their Medicaid coverage. And that is one of our real concerns as to how to boost and help the safety net situation in our community. And that's not the VHA population, but it's an extension of our work.
All right. So, I mean, given the fact that, you know, there are limitations in the world, let's say we, you know, give you, you know, the genie and the lamp, right? And you can make your wish come true to have robust primary care relationships for everyone, and counting those relationships and all of that. What is, in your mind, the unthinkable thing that should happen, or the big dream to get people this access?
I think you're asking 2 questions. I think, you know, I think it's easy to have and track the statistics of attribution as to whether someone is nominally part of a primary care practice. Delivering stable relationships is something that happens over time. It happens over years in an established relationship. I will say that you provided me this this question beforehand, and one of the things it occurred to me with the person-centered primary care measure, one of the questions they ask patients, have you and your doctor been through a lot together? And that is, to my mind, that is how we define a sustainable relationship.
No, I think that's
And
so important.
that's what we're all about.
Yeah, and I love that Callie was that introductory message at the beginning, because that's really the you know testimony, for a lack of a better term, that she provided is, walking through life's hard things together was amazing. So thank you so much. We have questions that are populating if you want to take a look at those. But for right now, trying to keep an eye on that 9 o'clock time frame. I just want to say thank you so much for everything that you shared. We will hop back and answer some questions. Also, Gary, if you don't mind putting your email that people can reach out to you directly into the chat, that would be great. But for now, I'm passing it over to the one and only Michael Fine.
Well, thank you, Patty, and thank you, Gary. That you've sort of set a standard for the rest of the country that lots of us are going to aspire to. I hope what you said is sparking ideas in everybody about how each of us can bring primary care to everyone in their own communities. I want to give a special thank you to the Healing Works Foundation and to Wayne Jonas for his incredible support of this Zoom and this whole process. For all of us, Primary Care for All Americans needs you to do three things. First, keep coming to these Zooms and bring 2 more people each time. That's the way we turn an idea into a movement. Second, leverage the power of 2 and start a local work group in your community. Somebody emailed me today and said, can you assign me to a work group? And I had to say back, well, gee whiz, there isn't a work group in your community yet, but if you can find one other person, you can and should start one. That's how we grow this around the country. And third, please include Primary Care for All Americans in your year-end charitable contributions, or even commit to making a small monthly charitable donation to sustain our work. $10 a month helps. $100 a month would be fantastic. The politicians have gone away for a while, we hope. Now let's focus on what matters and what we can actually change and change together. Remember, if we don't step up together, we get stepped on. Healthcare impacts all of us. When we work together, there's nothing we can't do. This isn't a Democratic thing. This isn't a Republican thing. This is an American thing, because we all need great healthcare, and each of our communities needs great healthcare for every single person. We're the public in public health. The time is now.
We encourage everyone to bring someone new to our next Teach and Learn in Zoom meeting on December 10th with Sandy Blount and Julie Oyemaja, sharing how integrating primary care and mental health can help communities bring primary care to everyone. Register on our website, www.primarycareforallamericans.org. And while you're there, please click Donate to support our work together with a monthly contribution. Please give what you can. Every little bit helps. We need and appreciate every single one of you for helping to spread this movement across our nation to get the change we need and you deserve. Healthcare for people, not for profit. Primary care for all Americans.
Well, we want to say thank you to everyone. We do want to hear from you. So if you could take a minute and fill out the form link that we just dropped in the chat so that we can get feedback on what you appreciated about this event, what we can do better, because we want you to bring people along and see you all on December 10th. While we are very excited to have this conversation, I think we should jump back into some questions. I think there were some good ones in there. What do you think, Michael?
Yes, please. Patty, can you read some of those questions from the chat?
Yeah, let me scroll back up. Just give me 1 second here. Let's see. Oh, there we go. All right, so we've got questions around how many years did it take for this process to become effective, and what kind of funding was available sort of in those early years. Gary, can you give us like a picture of sort of your starting foundation?
Yeah, our first conversations probably started 10 years ago. We really started in earnest about 6 years ago, maybe 7 years ago, when the employers said, we're going to participate, we're going to pay for this. They have some administrative costs associated with it, and they pay, I think their last year's total spend was $65 million between these employers. And they pay that 1%, and we've sort of built the process around that again, incrementally, month by month, over the last 5 years, really, to where we're more functional.
Did you
at
have
this point.
Yeah, did you have any like initial naysayers or any like groups in particular that sort of came against you at all?
We really haven't. We feel like once we got all three hospitals on board, and the employers were even more committed, and we just have these ongoing conversations, trying to come up with new ideas and build new processes.
Okay,
No
good to know.
naysayers.
No naysayers. Don't speak that into the universe, right? We don't want any naysayers. But we do like incentives. You mentioned incentives earlier. What were you looking at in terms of incentives that you were providing or that were provided?
Can someone clarify that question? I'm not sure.
Let me
So,
pop.
yeah, this is Larry Bauer. I'm one of the board members of Primary Care for All Americans, and I think twice you mentioned the term incentives. I think they were incentives to help increase the people getting involved, and I think there were also mention of incentives. I think it had to do with employees' behavior, but I'm not sure I'm remembering it correctly.
Yeah, okay, that triggers. So we are trying to talk with the employers about best practices for their HR groups and how optimally to incentivize folks to get a primary care provider. With open enrollment, we sign them up with a practice. We connect them with that practice so that they are registered with the practice when they have a need. Some employers give a money contribution to their spending account if they make contact with a primary care provider. We pay for preventive care visits without a copay and paid for, and they get a bonus to go get a wellness visit. So those kind of incentives where the employers try to drive their employees to primary care.
That's brilliant.
Thank you so much. George, I'm going to totally butcher your last name. Rygluth?
Nice job.
Did I do it?
Das ist ein deutscher Name, yes.
Oh, very nice. You had a question about engaging patients' care more through health coaches. Do you mind just, saying sort of
Sure.
what you were asking. Go ahead.
Sure. I mean, one of the things we've learned in the past couple of decades about primary care is that patients, even when they have a primary care physician, and it's a good primary care physician, the whole issue about taking care of that individual patient's social determinants of health is difficult for the primary care physician to address. And so we've been looking at ways to try to buttress or support the primary care physician through the use of, for want of a better term, health assistants like health coaches, health coordinators, navigators, social service people in the community. And the idea is to create for each neighborhood or community a directory of community or virtual based social services, so that if somebody is disabled and can only get around by wheelchair, that the van that comes to pick them up to take them to their doctor's appointment won't arrive without a ramp for the wheelchair to get onto the van. And so that's just a simple example, but these kinds of things happen all the time. So there's a question of do primary care physicians, we hear these stories about them being burned out and overworked and not happy campers, frankly. And is there a way to begin to take some of the load off of them with these skilled and trained health assistants? That's one part of the way in which we think it's possible. Another way is by using advanced data and analytics systems and capabilities to begin to get doctors out of the business of data collection, data vetting, data refinement, and data analysis and documentation. There are now systems that make it possible for primary care physicians, and all physicians in that fact, to not have to worry about those kinds of tasks, which they weren't trained to do. So that's where we're coming from.
So let me speak to that just a little bit, and we don't specifically use health coaches, but I'll use my practice as an example, and I'll go back to what I said, that team care needs to be real team care, and in our practice with data collection, for example, we have an AI transcriber in the room, and so a progress note is created by the conversation that goes on in the room, and we sign off on that and adjust it as necessary. So that's helped a lot. We screen all of our patients for social determinants, for anxiety, depression. If someone has a substance use problem, by the time I go in the room, I know about that. And my medical assistant has already done a brief intervention with them and referred them to our behavioral health clinical social worker. We have 2 clinical social workers who function in a lot of these roles. We have a community health worker who goes out in the community. We have 2 care managers, and we have a weekly care management meeting where we discuss our challenging patients. In those meetings, it's very interesting. We very seldom mention their diagnosis because their problems are all about their social determinants.
Right.
and their elderly frail spouse taking care of a demented spouse,
Yeah.
and their homelessness, and their 30% of people in our community can't afford to buy food at the end of the month because of their housing costs. All those
Right.
kinds of things we try to help them with, and
Well, that's great.
so that's sort of how we've structured it.
Sounds good, Gary.
Those comments.
Sounds great.
Thank you, guys. So I saw a very interesting thing pop up to me, and since I'm fielding questions, we get to look at those. So Paul Bierens popped up and asked a question about AI scribing tools. Paul, what are you talking about?
Oh, I sure hope most primary care doctors know what I'm talking about. Uh, there are now multiple companies providing AI scribing tools that allow docs to actually look patients in the eye instead of staring at a screen, that record an entire interview and then turn it into a soap note. Um, I can't tell you one's better than another. I'm not using them. I'm retired, but I believe that that is going to be a major factor in relieving some of the pressure on primary care docs. And I was very interested to find out if Dr. Knaus has started using those.
So I'm retired also by 3 years, but all of my ex-partners are using that now for a couple of years, and they have the computer in the room, and that creates the progress note based on their conversation. And I have to say that the notes I've read from them are not as heartfelt and authentic. All the information is there and then some, but it doesn't quite capture the soul of the visit. And that's sad to me.
If I could make a follow-up comment, weekly, the Artificial Intelligence in Medicine group meets with office hours for free. About half are docs, about half are techies. And this stuff is moving very fast and going to get a whole lot better very quickly.
Yeah, yeah, great.
Very interesting to see how we can use tools. We started talking about that a little bit last week, how you use it as, sort of a launching off point. Brian, I see your hand is up. Would you like to come off mute and ask your question?
Yeah, first I wanted to inspire other people to raise their hands and speak up. I think that would be great. I have a couple of questions that are like kind of counter nerdy, like for people on this call who maybe aren't physicians who don't know all the acronyms. I understand everything, but this is for other people. You said something about employers. You were talking about employers, and you said something about 5 to 9% involving primary care. What were you referring to, if you remember?
Referring to global primary care spend. In Colorado, we have a statute that mandates that insurance companies pay 1% more per year for primary care each year to reach upwards of 13%. I think that's what the statute talks about. And we have elected to measure primary care spend in our Valley system. And so that's what we're talking about. Some of our employers spend about 5% of their total spend on primary care. 2 of them spend about 9% on primary care.
Okay. And you're aiming for what? 13?
We're
in Colorado?
I think the data, Michael's a better one to talk about this, but I think the data shows when you get up around 13% or more, you save a lot more money. And that's that's what's behind that. Yeah.
And then you said something about attribution rates. What does that refer to?
So attribution rate means, are you attributed to a usual source of care? Do you have a primary care doctor? And we track that to be able to, and gradually we're just increasing that. We were about 50% in this population 4 years ago. Now we're up to almost 70% in this population. And that's by design. And we think that helps improve care and costs.
And someone on this call can probably correct me, but I think nationally that number's at about 40%. Is that right?
That's the number that I've heard.
That's the number I've heard. I think it's what they talk about.
I would second that. Yeah.
So it's at about 40%, and you're at 70% where you are.
Yes.
That's impressive. And then my final question. Oh, sorry, Michael.
Oh, just the data that suggests 43% of American adults have a robust primary care relationship actually measures robustness of relationship, not usual source of care, which is a different thing, but that's pretty wonky. The thing that I think I think most of us think that what really is going to matter at the end of the day is a measure of a robust relationship. What Callie said, or what was said before about, have I been through something? Have a patient and doctor been through something meaningful together, and do they trust each other? We don't have great measures of that at the moment. It sounds like some of Rebecca's work may get us there. But that's what I think we ought to be focused on measuring at the end of the day. That we've got as a nation, we've got a pretty long glide path to making sure we can measure that in a robust way.
Right.
Brian, did you have one more question?
Oh, I've got several more. I could keep going.
Well, hold on to one more, and
I'll wait until there's another pause.
Yeah, wait for. But I did see one from Mirna. Am I saying your name correctly? You had asked something about what does the brief intervention look like with MA and patient. Do you mind expanding on that just for us?
Hi,
Oh.
my name is Myrna. Yeah, you said it very well. So yeah, I just kind of want to know more about the interaction with the medical assistant and the patient. Like, did they receive training prior to triaging the patient, I would say, when they go into the room? And, how do they know whether this person actually needs help and they should have like a warm handoff to the provider? Um, yes. Yeah. So did they have training prior to helping the provider? How does that work?
So basically, we use the SBIRT model, which is screening, brief intervention, and referral for care, is what SBIRT stands for. And each of our medical assistants have been trained and have a script for how to interact with somebody who screens high for alcohol abuse, for example, or who screens high for loneliness. We have a sort of an algorithm where our medical assistant intervenes, gives them information, talks to them, and then we or the behavioral health provider take it from there. So it takes so much of that off of our plate in terms of knowing how to do that. Does that make sense?
Yeah, no, it
Yeah.
does. Thank you so much.
Okay.
Perfect. Shameless plug here, as I was hearing you guys go into some of the defining some of these things and the statistics that you all are agreeing to. Lindsay Lopez is on this call. She is our fantastic social media manager. We are looking for sort of these bite-sized pieces for everyday people to understand why they would want to access primary care, what kind of experience should they expect, and all of this. So feel free to write to her in the chat now if you've got a couple that are bubbling up. Maybe it's with patient interactions that you've had. I am non-medical, so sometimes I get a little lost in the jargon that might happen. It happens, right? When you all start speaking the same language, because you can talk so much faster when you're using jargon. But to really make this movement move with the tens of thousands of people that Michael wants to have join us, and we all want to have join us, we need to start helping people along in that journey. So find us on our social media pages. If you don't have social media, I would encourage you, get it just for this, to follow us and push it along. We are on LinkedIn, Facebook, Instagram, and Twitter. These recordings go out. We definitely splice pieces of this out so that we can move this. But social media has proven time and time again to be not the movement maker, but a pusher of movements. So please help us in that way. George, you did such a good job of raising your hand. I'm going to call on you next.
audio here. Thank you. So Gary, I just have one other question on this, trying to provide aids to camp for doctors and patients and health assistants. Have you guys gotten into what is euphemistically referred to as distributed care, where you give for your chronic, your patients with multiple chronic conditions, you teach them and give them, home blood glucose monitoring kits, or blood pressure cuffs, or OX measuring devices, and these devices can send, now with the advances in data processing technology, these devices can send the measures automatically from the device to an AI engine that receives the measure, and then there's a whole story beyond that. But how are you guys doing with the distributed care stuff, remote patient monitoring devices, etc.?
So we sort of do it the old-fashioned way. We have oximeters, we have blood pressure cuffs, and we send those home with patients.
You do?
Our
Okay.
our care managers manage our diabetic patients, and they take care of all of those quality measures and get them in for regular visits and that sort of thing. We've interviewed a couple of vendors of that kind of care, and not sure that's quite ready for prime time for our community yet, but worth looking at further. There's a lot of vendors are trying to get on that bandwagon, if you will, and they make money. I'm always suspicious of the middleman. So we're just trying to be careful with that.
Yeah, and just quick follow up on that. You're aware, I'm sure, that CMS has created CPT codes for the successful use of remote patient monitoring devices. It's been somewhat of a mixed experience. We're working with some FQHCs on that, and it's not easy to deal with CMS, but you can get revenue back into the practice from those programs.
Yeah, I agree. And the couple vendors we looked at were making more money than we were by doing the process, and that doesn't set well with us. And we're not private practices. We are employed practices by and large, and so we're not looking for every dollar that way.
Yeah, great, thanks.
Well,
Patty, there was a great question in the chat from Ashley. I don't know if she's still on.
I was looking for her. Yeah.
About how you make pharmacists part of the primary care team. Are they part of what you're doing?
Yes, I didn't mention that. That's part of our team. We have a clinical pharmacist. We actually share her time with two other practices, but she's in our practice 2 days a week, and she is our well, we use her for a lot of deprescribing kind of approaches. She is our liaison to the discharge planners at the hospital, and she checks and double checks every discharge med list and goes over those with the patients, and just probably once a day with a patient finds an error that was made somewhere in that transition of care. And so that's been just a critical part of our team.
Great, thank you so much. Well, there are a ton more questions, and I wish we had more time. We probably have time for one more question. Daniel Dow.
Hi, thank you. I had a question. When you mentioned that when the expenditure on primary care increased, above 5% up to 9% or so, that you saw cost savings overall. And I was curious where the cost savings were noticed most, whether it's interventional procedures, surgeries, ER visits, or hospitalizations?
I think that's hard to I think that's hard to measure. We try to reassure our employers that if they didn't have a primary care centric plan, they would be paying 10% more. We think that it is in coordination of care. We think it is in helping with those social determinants of health, so people don't end up in the ER, so they don't end up in the hospital. Our care managers are calling those high risk patients every day and checking in and making sure that they are not having new problems that are going to end them up there. And we always say, call us first. If you've got a usual source of care, you don't go to the ER when you have a problem, you call us, and there's always one of us available. And so I think those are the kinds of things. What we aspire to, I think, and we just right now we're just a simple primary care centric PMPM, like I described. I think probably over the next couple of years we will move toward a blended payment of some risk payments up front, risk-based payments up front, and augmented with fee for service. That's the model of CPC, which we've all been involved in the past. That's the model of primary care first, and I think probably getting the providers to have some skin in the game with a little bit of risk will probably make a bigger difference over time with some cost and utilization. Right now, we're incentivized to refer people because it's fee for service. And so I think we see a lot of stinting where people are not given the full measure of primary care.
And correct me if I'm wrong, there are others who probably know these numbers better than I, but I think in demonstrations that have used a direct primary care model, where everybody is effectively not just attributed, but has a robust relationship. I think the savings are looking more like 20 and 30% because of the tightness of that relationship.
Yeah, I think one of the most important things that comes out of a trusted relationship with your primary care physician is reassurance that either nothing is wrong or nothing needs to be done, and you really have to have that long-term relationship to be able to trust that advice and be willing to not consume healthcare when it's not needed. So I definitely agree with that.
Well, thank you so much, Gary. I really appreciate your time and all of the questions that you answered. We really hope to see you all at our next Zoom meeting, which is on December 10th. We encourage you to bring someone. If that feels way too far away, find a work group to join in between. Follow us on social media. We are happy to interact with you to build this movement as we continue to rock and roll forward. Michael, any parting words?
Just thanks to everybody for being here. And like Patty said, if there's no local work group in your community, start one. Get one person and go to work. We will have lots of resources to help support you, but we need you in your own neighborhood and community to get this going and to spread it. Thanks to everybody. Gary, you were fantastic. Callie, you were fantastic. Gabrielle, you were fantastic. Patty, always great. Thanks to everybody for being here tonight. We hope to see you in about a month.